Hey guys, my name is Ahmad. I'm a third-year emergency medicine resident, and my case presentation today is titled Unmasking the Enigma, Staphylococcus lugdunensis Endocarditis in an elderly woman with atrial fibrillation and cognitive challenges. The way I'm going to present this case presentation is by painting a picture and depicting what happened because there's a lot of small details in this case. We have a 66-year-old female that presented to the ED for 1 week of lethargy and altered mental status that began a few days into her trip to the Caribbean. Patient wasn't able to give a history, so most of it was obtained from her sister, who was on the cruise trip with her, and her husband, who lived at home with her. A bit on her past medical history: she had an infiltrating ductal cell carcinoma, osteoarthritis, and a portacath due to a septic right knee. A little bit more about her history. Family history was non-contributory. Surgical history: patient had a mastectomy. She had a right total knee replacement and a Roux-en-Y gastric bypass. She had been in remission since 2017 after chemotherapy. As aforementioned, the clinical presentation: patient came in, she was lethargic, altered, she had nausea, no vomiting, and diarrhea. She had decreased PO intake. The family had driven all the way from New Orleans to Searcy, Arkansas, because that's where they lived. Patient's vital signs, as you can see, were not very remarkable. She was anointed to person in place. Her pulmonary exam showed some inspiratory crackles. Her vital signs, similarly, were not remarkable. She had a low-grade temp at 99.1. She wasn't tachycardic. She wasn't hypotensive. I'm just going to post the pertinent lab findings because there was a plethora of labs that were obtained. She had an elevated white count at 14.6. She was hyponatremic. She had a bump in her troponin at 1.39. Her UA was negative, respiratory panel was negative, and ABG was unremarkable. Chest x-ray was obtained, and as you can see, the findings are very nonspecific. They show the left diagetic portacath, some worsening of bilateral airspace disease, maybe pneumonia, maybe maybe edema, maybe multifocal pneumonia. 15 minutes after her presentation, there was a sudden change in the patient's status. She developed atrial fibrillation with RVR, so cardiology was consulted in the setting of an elevated troponin. They recommended therapeutic Lovenox. Patient was already given 2 liters of LR, and she spontaneously converted. Obviously, our differential for this patient was very broad: infectious versus cardiac etiology versus something like a pulmonary embolism. So we did a CT with PE protocol. And what it showed was surprising, to say the least. There was a density and thickening along the left side of the mitral valve. So our differential now included endocarditis as well. So the patient was started on vancomycin, Herceptin, and azithromycin, because we did include Legionnaires' disease as part of our differential due to her altered mental status, hyponatremia, and diarrhea. She was admitted to the ICU and observed there. She did go back into atrial fibrillation. Cardiology came, got a formal echo, and as you can see, the vegetation on the mitral valve was significantly large. She didn't have any common signs of endocarditis, such as Osler nodes, Janeway lesions, and her fingernails were painted, so you couldn't really distinguish splinter hemorrhages. The patient received definitive management, which is ultimately surgery. Her blood cultures grew Staphylococcus lugdunensis on all 3 sets. Cardiology was again consulted. We had to transfer her to a hospital that had cardiothoracic surgery. She was transferred the same day, and that's when she had her definitive surgery of mitral valve replacement. So ultimately, a discussion of this: Staphylococcus lugdunensis is a coag-negative, catalase positive, gram-positive bacteria that is associated with high mortality. Specifically, endocarditis caused by this bacteria usually involves the native valve instead of prosthetic valves. There are no reported cases that we could find of Staphylococcus lugdunensis, endocarditis, and new onset atrial fibrillation. This story describes a unique presentation of a woman that presented with these symptoms. Early recognition and interdisciplinary management and timely surgical management remain crucial for achieving favorable outcomes in such cases. Further research and reporting of unique presentations like this will contribute to a better understanding of Staph lugdunensis endocarditis, its prompt recognition, and timely management. Thank you for your time.